the distal convoluted tubules. So in the early distal convoluted tubules, you are still actively reabsorbing sodium and chloride. You also reabsorb some calcium. So sodium chloride is reabsorbed across the apical membranes via the sodium chloride symporter. Sodium is actively pumped across the basolateral membrane via the sodium-potassium ATPase, and then chloride diffuses down an electrochemical gradient through channels. This segment is impermeable to water, thus it is a diluting segment, and you are still diluting the ultrafiltrate. So once again, it is the early distal convoluted tubules that has the lowest osmolarity out of the entire nephron. Thiazide diuretics block the sodium chloride symporter in the distal convoluted tubules. Blocking this transporter enhances calcium reabsorption in the distal tubules, and this can lead to hypercalcemia. Now, whenever you have increase in calcium levels, this will activate the calcium sensing receptors in the parathyroid glands, and that will suppress PTH levels. So this patient should have low PTH levels. Thiazide diuretics are sometimes used to increase plasma calcium. So thiazide diuretics are a mild diuretic, and we use them to treat hypertension. Sometimes we use them as diuresis for heart failure, but again, loop diuretics are more potent diuretics because they work earlier in the nephron. The distal convoluted tubules will reabsorb about 5% of the sodium that was filtered. Gittelman syndrome is a genetic disorder resulting in a mutation of the sodium chloride transporter. Patients will have hypokalemia, alkalosis, with a low urine calcium. So this is just like being on a thiazide diuretic. So this is an image of the distal tubules. Here is your sodium chloride transporter. This is where thiazide diuretics will work. This is where PTH works. PTH increases reabsorption of calcium in the distal convoluted tubules. You reabsorb about 8% of your calcium right here. PTH enhances this. Activated vitamin D also directly works on these cells to increase reabsorption of calcium by increasing genetic expression of calbindin. Calbindin is a transporter protein that increases the transport of calcium, and this is the distal tubule. So the distal tubules is an important site for regulating calcium reabsorption because this is where PTH works. PTH opens the calcium channels, and that increases calcium reabsorption, and this can have an important effect on your serum calcium levels. This is a site where you actively reabsorb calcium. Activated vitamin D also increases calbindin synthesis in these cells. That also enhances reabsorption of calcium by these cells. Now, activated vitamin D also synthesizes calbindin in the small intestines, and that leads to increase in calcium absorption in the small intestines. So the function of activated vitamin D in the intestines is to increase absorption of both calcium as well as phosphate. That's in the small intestine. But here, in the kidneys, activated vitamin D functions to increase the reabsorption of calcium. And remember, the action of PTH in the kidneys is very important. The function of PTH right here in the distal tubule is to increase reabsorption of calcium, but PTH in the proximal tubules inhibits reabsorption of phosphate, and that leads to an increase in renal excretion of phosphate, and that lowers your serum phosphate levels. PTH also activates vitamin D in the proximal tubules. So PTH has a very important effect in several cells in the kidneys. Now for the collecting ducts, the final segment of the nephron. The collecting ducts are composed of two different cells. You have the principal cells and the intercalated cells. Now the principal cells, let's spend a minute on. The principal cells on the luminal membrane contain sodium channels. These sodium channels are referred to as the epithelial sodium channels. Because of these channels, sodium will follow its electrochemical gradient that is created by the sodium-potassium ATPase into the cell. The sodium-potassium ATPase is located on the basolateral membrane. So those are your principal cells that are located in the collecting duct. The principal cells are the site of action of mineralocorticoids, such as aldosterone. Remember, aldosterone is a steroid hormone. Steroid hormones bind to nuclear receptors and increase the synthesis, they increase the transcription and translation of brand new proteins. The proteins that aldosterone synthesizes are the epithelial sodium channels and the sodium-potassium ATPase. So they lead to increased production of the epithelial sodium channels in the luminal membrane and the sodium-potassium ATPase in the basolateral membrane. The net effect of this is to increase the reabsorption of sodium and to increase the secretion of potassium by the principal cells. Now, this is a very important slide to understand. We're going to take a look at how aldosterone functions in the collecting duct. So we mentioned the function of aldosterone in the principal cells to increase synthesis of sodium-potassium ATPase in the basolateral membrane, as well as increase synthesis of the epithelial sodium channels in the luminal membrane. So let's take a look at this. Here is your lumen. Here is your luminal membrane. Here is your basolateral membrane. Here's your sodium-potassium ATPase. Here's your sodium channel. Now, when you increase the number of sodium-potassium ATPases, you increase the reabsorption of sodium and secretion of potassium. So, you increase sodium reabsorption, but with sodium goes water. So that increases volume retention. So that increases your plasma volume and increases your blood pressure. It does not give you hypernatremia. Very important. Number one. Number two, increased secretion of potassium. Now here's an important point. Remember, sodium-potassium ATPase will take 3 sodiums in exchange for 2 potassiums. So when you activate the sodium-potassium ATPase, because you're exchanging 3 cations for 2, you are creating a negative luminal membrane. Notice that you're creating a negative luminal membrane. Well, when you do this, that makes the lumen more attractive for protons. Now we're going to talk about the intercalated cell. So here's your intercalated cell. The intercalated cell contains proton channels. When you increase the negative charge in the lumen, you increase secretion of protons. So, therefore, one of the effects of aldosterone is to increase secretion of protons by the intercalated cells. One of the effects of aldosterone is to increase secretion of protons by the intercalated cells. That's an important point. Now, where do these protons come from? Well, these cells, the intercalated cells, have a carbonic anhydrase. They take water and carbon dioxide to make a proton and a bicarbonate. Now, where does this carbon dioxide come from here? This carbon dioxide doesn't just appear from nowhere. This carbon dioxide comes from the Krebs cycle. These cells have mitochondria. The mitochondria are producing CO2 via the Krebs cycle as a byproduct of the Krebs cycle. That's where the CO2 is coming from. You take water and you produce protons and bicarbonate. Now, here's what's important. This is not bicarbonate that was filtered. You're not reabsorbing bicarbonate that was filtered. What you're doing in the intercalated cells is you are synthesizing brand new bicarbonate. You are not reabsorbing bicarbonate here. You are synthesizing new bicarbonate. So remember, one of the functions of the kidneys is to control your acid-base balance. This is one of the ways that they do it, by the intercalated cells synthesizing new bicarbonate. This is how they do it. So that's a very important point. This is a new bicarbonate molecule. So, for every proton that is secreted, a new bicarbonate molecule is synthesized. Therefore, aldosterone, by increasing secretion of protons from the intercalated cells, increases synthesis of new bicarbonate molecules. Therefore, aldosterone can lead to high serum bicarbonate levels. We call this a metabolic alkalosis. So, high aldosterone states can lead to three things. 1. Volume retention. 2. Hypokalemia. 3. Metabolic alkalosis. Because aldosterone will increase reabsorption of sodium and water, giving you volume retention. Aldosterone will increase secretion of potassium, leading to hypokalemia. And aldosterone will increase secretion of protons, leading to metabolic alkalosis. So high aldosterone states can lead to volume retention, hypokalemia, and metabolic alkalosis. And that's an important concept. So that's what you could see with high aldosterone states. Now, what would happen if you lost this channel? What would happen if that channel stopped working? You would not be able to get acid in the urine. You would lose the ability to acidify the urine. We call this a distal renal tubular acidosis. We call this a distal RTA. That's what a distal RTA is. You cannot get acid in the urine. So, again, you would have a low serum bicarbonate. Your serum chloride would go up, so you would get a hyperchloremic or a non-anion gap metabolic acidosis. You would lose potassium in the urine. You would have urinary loss of potassium, so you would see hypokalemia. Now, this time, what would happen to the urine pH? Well, the urine pH comes from this right here. Urine pH comes from the free protons in the urine. And if you cannot get free protons in the urine, you will have an elevated urine pH. So the distal RTA, now you will have a high urine pH. You will have an alkaline urine now, because now you have lost the ability to acidify the urine. So in the distal RTA, you will see a high urine pH because you cannot acidify the urine. So that's a distal RTA. So that's the distal RTA. This is what we call it. It's also known as a type 1. So a type 4 RTA. Type 4 RTA is also known as hypoaldosteronism. Think about what would happen in low aldosterone states. In low aldosterone states, you would not be able to secrete potassium. So now you would get hyperkalemia. So in low aldosterone states, you would lose the ability to secrete potassium. So you would get hyperkalemia. You would also lose the ability to secrete protons. So you would get, once again, an acidosis. So now in low aldosterone states, you would get what we call a type 4 renal tubular acidosis. And you would see hyperkalemia. So that is type 4 RTA, which is known as hypoaldosteronism. So the potassium-sparing diuretics. Some work by blocking the epithelial sodium channels, like amiloride. Some work by directly blocking aldosterone receptors. So spironolactone and eplerenone work by directly blocking the aldosterone receptors. Eplerenone is more specific for the aldosterone receptors than spironolactone. Spironolactone will block other androgen receptors as well as aldosterone, and that's why a common side effect of spironolactone is gynecomastia in men, whereas eplerenone is more specific for mineralocorticoids and will not cause gynecomastia. Amiloride and triamterone will block the sodium channels. Now, these diuretics, by inhibiting aldosterone, will spare the potassium. They will inhibit the secretion of potassium. These potassium-sparing diuretics are not very potent diuretics. Remember, in the collecting ducts, you only reabsorb about 3% of your total potassium. So these are not very potent diuretics, but they are important because by blocking aldosterone, you will spare the potassium. Now, we use these diuretics in patients that have secondary hyperaldosteronism, such as patients with cirrhosis or patients with congestive heart failure, because these patients have high aldosterone levels leading to increased potassium secretion, and they're at risk for hypokalemia. So by using these diuretics, you will protect them from hypokalemia. And clinical trials show that these diuretics actually improve mortality. So that's why they're important. But we realize they are not very potent diuretics. So we really use them, again, not to give you a potent diuresis, but to block the effect of aldosterone in patients with secondary hyperaldosteronism and to really spare them from getting hypokalemia. Liddell syndrome is a genetic disorder resulting in gain of function of the epithelial sodium channels in the collecting duct. This leads to enhanced sodium reabsorption as well as potassium secretion. As you can imagine, patients would be hypertensive due to increased sodium retention, hypokalemic due to increased potassium secretion, and they also would have a metabolic alkalosis. The same effect as if they had hyperaldosteronism. The treatment would be to block the sodium channel. So the treatment would be amiloride, block the sodium channel. So the principal cells are also the sites of ADH. ADH, remember, has two different receptors. In the arterioles, in the peripheries, you have V1 receptors. So smooth muscle cells in arterioles in the peripheries have V1 receptors. And those cells are coupled to GQ and an inositol triphosphate, and that will lead to an increase in intracellular calcium concentration, and that will lead to vasoconstriction of the arterioles, and that will lead to increase in TPR, and that will increase your blood pressure. Here, in the principal cells, ADH has V2 receptors. In the principal cells, V2 receptors are coupled to GS, which will activate adenylate cyclase, which will lead to an increase in cyclic AMP. The ultimate effect is to insert aquaporin channels. Aquaporin channels will lead to an increased reabsorption of free water, and that will dilute your serum sodium. So the effect here is to control your serum sodium levels. Now remember that ADH will also lead to an increase in reabsorption of urea. We mentioned that as well. Now, there are two stimuli for ADH. One is increase in osmolarity. So, when you eat sodium, there's an increase in your serum osmolarity. Osmoreceptors will sense an increase in osmolarity, and that will lead to an increase in ADH release. So you can increase reabsorption of free water and decrease your osmolarity. That's one stimuli. The second stimuli is low volume. In low volume states like hemorrhaging, dehydration, diarrhea, vomiting, low volume states will increase ADH secretion. So those are the two stimuli for ADH. Low volume states will increase ADH secretion. And this is why you can get hypovolemic hyponatremia, because low volume states can increase ADH release, and that can lead to increased reabsorption of free water, and that can cause hyponatremia. So the intercalated cells are ultimately involved in acid-base regulation. This is a high-yield point. The luminal membrane contains proton ATPases, which actively pump protons into the lumen. Now, most of your body's protons are eliminated in the form of buffers. These buffers are phosphate and ammonia. So step one loves to ask you about your buffers. Step one loves to ask you about how acid is eliminated, how acid is excreted in the urine. Now, protons are pumped into the lumen. We looked at how they're pumped into the lumen, and they bind to your buffers. One buffer we mentioned is phosphate. Now, where does phosphate come from? Phosphate comes from your diet. You eat phosphate, you filter phosphate. 85% of the phosphate you filter is reabsorbed in the proximal tubules. The other 15% comes over here to the distal tubules and is used as a buffer. It binds protons and is used to buffer acid. This is where about 40% of your acid uses phosphate as a buffer. What about the other 60%? So the other 60% uses ammonia. So ammonia is a very important buffer. So ammonia binds the protons to form ammonium. This is how most of your acid is buffered. Now, where does the ammonia come from? This ammonia is produced by proximal tubule cells. The proximal tubule cells will take glutamate and break it down to ammonia, and this is where ammonia comes from. And that ammonia is used to buffer acid. That's a very important concept. So for every proton that is excreted, a brand new bicarbonate molecule is produced and added to the body. Aldosterone stimulates secretion of protons by the intercalated cells. Therefore, excess aldosterone can result in a metabolic alkalosis. And this is a high-yield point that they love to ask you about on the exam. Okay, let's talk about metabolic alkalosis for a minute. This is a concept that they like to ask about. Vomiting. In patients that are vomiting, you get a metabolic alkalosis. The initiation is loss of hydrochloric acid from the stomach. You can also see this with nasogastric suctioning. The initiation is loss of hydrochloric acid from the stomach. This leads to you get an increased production of bicarbonate by parietal cells, and the blood leaving the stomach has a high bicarbonate. That's the initiation. The maintenance is due to low volume, because when you vomit, you also lose volume. That stimulates renin release, which leads to aldosterone release. Aldosterone will lead to increased synthesis of bicarbonate by the intercalated cells. Now, these patients will have a low urine chloride. Why? Because you're losing chloride in the vomit. And this is an important point because the step one will ask you, how can you tell somebody has a metabolic alkalosis from vomiting? The answer is the urine chloride. If there's a low urine chloride, they have a metabolic alkalosis due to vomiting because they're losing chloride in the vomit. Now, this is known as saline responsive metabolic alkalosis. What does that mean? That means if you give them a saline infusion, you will suppress renin release, you will shut down aldosterone secretion, you will shut down the metabolic alkalosis. That's what saline responsive means. Now, a contraction alkalosis is a patient that develops a metabolic alkalosis. This can be seen in patients that are taking loop diuretics or thiazide diuretics. Now, I very commonly see this because we use these diuretics a lot in our patients. Loop diuretics, thiazide diuretics will lead to low volume states because you're diuresing, you're dehydrating the patient. This will stimulate renin release, leading to activation of the RAS system. High aldosterone and angiotensin II will lead to what we call a contraction alkalosis. Increased synthesis of bicarbonate by the intercalated cells. This time, you will see a high urine chloride because you will see an increase in the excretion rate of sodium chloride. So the test that tells you the difference between vomiting and patients that are using diuretics is the urine chloride. Here you will see a high urine chloride. That's an important point. These patients are also saline responsive. This is a low volume issue. Given a saline infusion will replace the volume, shut down renin secretion, and shut off the RAS system, and that will correct the metabolic alkalosis. Conn syndrome or primary hyperaldosteronism, you have an adenoma of the adrenal gland, you have an adenoma of the adrenal cortex or hyperplasia that leads to high aldosterone levels, leading to increased synthesis of bicarbonate by the intercalated cells, and this leads to a metabolic alkalosis. These patients, however, are saline non-responsive, and this is not a low volume state. So giving these patients saline will not reduce aldosterone levels, and giving these patients saline will not improve the metabolic alkalosis. Urinary buffers. So the exam likes to ask about excretion of acid. So turns out that only a very small amount of acid is excreted as free protons. The minimum urine pH is 4.5. You cannot get the urine pH less than that. So that's a very small amount of the total acid you excrete. Your body every day is producing a high amount of acid. Every day you have to excrete that acid. 40% of the acid you are producing is excreted as titratable acid. Titratable means bound to phosphate. This phosphate comes from your diet. This phosphate comes from the phosphate that is filtered. The other 60% is excreted as ammonium. Now, ammonia is produced from glutamate by the proximal tubule cells. That ammonia binds to protons to form ammonium. So, 60%, most of your acid is excreted in the form of ammonium. Now, here's an important point. Ammonium is always excreted with chloride. So, never excrete ammonium alone. You excrete ammonium chloride. So when you look in the urine of these patients, you will see ammonium chloride. Ammonium is always excreted together with chloride. Opposites attract. So you always see ammonium chloride excreted together. So, what is the urine anion gap? Well, I mentioned that ammonium is always excreted with chloride. Therefore, if the urine ammonium is high, the urine chloride is high. This gives you what we call a negative urine anion gap. What a negative urine anion gap means is that there's more anions than cations in the urine. We don't have a way to measure ammonium in the urine. We just don't. So if you want to see how much ammonium is in the urine, you can check what we call the urine anion gap. You look for sodium, you look for potassium, you look for chloride. You look for your two cations, which is sodium and potassium, and you look for your anion, which is chloride. If you see, for example, let me give you some numbers. Let's say your chloride is 200, your sodium is 140, your potassium is 20. If you add these numbers up, you see that there are more anions than cations. We would say that this is a negative urine anion gap. That would tell me that there's more ammonium. That would tell me that there's ammonium in the urine. That would tell me that this urine has a high amount of acid. If the urine ammonium level is low, the urine chloride level would be low, and that would give us what we call a positive urine anion gap. So, in an acidemic state, here's how the urine chloride is helpful. In an acidemic state with a normal renal response, let's say diarrhea, for example. In diarrhea, you lose bicarb in exchange for chloride, and I mean profuse diarrhea. When you have severe diarrhea, you lose bicarb in the stools in exchange for chloride. In severe diarrhea, you develop a hyperchloremic metabolic acidosis. The kidneys have to come to the rescue. Another example would be diabetic ketoacidosis. In DKA, your body's in a very high acid state. So if your kidneys are functioning normally, your kidneys have to come to the rescue. So in these two situations, you would expect to see in the urine a low urine bicarbonate because the kidneys should be reabsorbing bicarbonate. You expect to see a low urine pH. You expect to see a high urine ammonium because the kidneys should be excreting acid. You expect to see a high urine phosphate because the kidneys should be excreting acid. Now, in renal failure, the kidneys are not functioning. In renal failure, you have lost the ability to excrete acid. So in renal failure, you should see low urine ammonium levels and low urine phosphate levels. The kidneys have lost the ability to excrete acid. So in renal failure, you should see low urine ammonium levels and low urine phosphate levels because the kidneys have failed and they're no longer doing their job.